the patient, well, who's got shorts? Nobody. Well, I'm not doing it because I want to show it to you correctly, because this is how you should be doing it. Because as soon as you go and you do stuff over clothes and then you can't see something and then you choose to grade it anyway, and this happens when you get in the clinic. People will go, oh, I'll put them in a gown, but I'm leaving their pants on. Which is okay when you're treating the low back if you can get to all your structures. But when you go to do the exam, how are you doing those dermatones? Well, I guess if you could just pull the pants leg up, I can do at least, right, 4, 5, and 1 if I can get the knee down, right? But try and do a medial hamstring reflex. It gets really difficult to see. But anyway, so anything in particular you want me to start with? Okay, so I'm not doing head to toe, I'm doing cervical and I'm doing lumbosacral. Head to toe, completely different beast. Okay, so this is your basic neuro exam. If it's a neck complaint, headache, right? Or if you're talking low back, one or the other. All right, so starting with dermatones. So you have your patient sitting there, and he could be sitting, and I always put him into anatomical position. And if you don't do this, you will make a mistake at some point, probably when you're under testing conditions, when it counts the most, like at boards or something. So just get in the habit of doing this so you don't accidentally, because you're stressed out, mess up, right? Good habits. So you tell the patient, see this? I'm gonna run this down your arm. It's gonna kind of feel like this, feel that, right? Feel it, okay. And I do not like these. Remember, I think these are not good because we talked about this, yes?
Yes.
It's 90 degrees, you should be holding it like this. And they're so short, they have no weight to them. You should be running them down their skin like this. This all of a sudden gives you awkwardness. But anyway, so it's gonna feel like that. I'm gonna test you from side to side and you tell me if it's the same or if it's different. I'm gonna have you close your eyes. Because he's got sleeves on, I'm gonna have him pull his sleeves up, or I'm just gonna pull them up for him, okay? So I'm gonna say, tell me, how does this feel like compared to that? Same, okay. This, and I just come down the thumb. You don't need to come down both fingers, right? C6 is thumb and index finger. Does this feel the same as this? Mm-hmm. Okay. Then when you're doing C7, you know how on some of the charts it'll show you a little sliver coming up here? Don't do it up here because it's not the same on everybody. And how do you know you're actually hitting that sliver, or if you're actually on C6 or C8? You don't, but it's always right down through the center of the palm, out the middle finger. Does that feel the same as, does that feel the same as that?
Yes.
Sorry. My hair is not in a good place. Okay, so that's your C8, C7, sorry. C8, does this, and I use the pinky, does this feel the same as this? Okay, and then T1 is really just above and below the elbow. Does this feel the same as this? And sometimes people will say, don't touch them anywhere else on the arm. Don't touch them or distract them. But I'm not gonna, I move them away as long as I'm not close to the area that I'm testing, because I don't wanna be doing this. See the proximity here? You know, so he's in good shape. You have someone with a little bit of belly or really big boobs, you don't wanna get that pinwheel too close and have them get, uncomfortable, okay? That's your upper extremity dermatones. 5, and it's always in this motion, right? From proximal to distal. 5, 6, 7, 8, and 1, okay? It's always this side to this side, this side to this side, this side to this side. The day that you go this, 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 and then you go this, 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 then you nullified the whole exam. So it's always side to side, side to side. If you remember that the neuro exam is always a bilateral comparison, okay? All right, to continue on the upper extremities. You have DTRs, you have myotomes. Tell me about your myotomes first. What do you use for C5? What do you guys use?
Me too.
Generally, I'll walk behind the patient. I don't like to stand in front of them because I don't want to be between their legs. I don't want my chest in his face. It's uncomfortable for me, and it could be a bad thing. So have him put it like this. Now remember, this is actually a little bit high for him, and normally you wouldn't have him sitting so high because you want to be able to actually tell the patient, I'm going to push down on your arms and resist me. Do not let me push it down. I'm tall and I'm going up onto my tippy toes, and quite honestly, that's a real bad position for my shoulders to use a whole lot of strength. Right? You want to provide maximum resistance and see if he can resist it. It's going to vary from person to person depending on how muscular they are, how strong they are. okay? But if it gives away really easily, but you go, that guy's stronger, you didn't give it, you know what I mean? Either something's wrong, it's causing pain, there's a weakness, or he's not trying. Right? Yeah.
Should we do both arms at once like that?
This is one of the few ones you'll do bilaterally, because this is what happens. Hold your arms up. Okay, resist, don't let me push it down. And what happens is they start going like this. They start going laterally. Same thing with traps. If you do, right, when you're checking, raise your shoulder, do a shrug. Right, it's the same, because otherwise you get this sort of motion. Thanks. Okay, so deltoids for C5. I use biceps for C6. So what I'm going to do, patient, and put you in this position. You don't want to completely flex. You support underneath, right, underneath the humerus, distal humerus, okay? And then you have a long lever here, or lever, pick one, or use either. I like lever. Okay, great. And you're gonna go, don't let me pull your arm down, resist, right? So it's like this, yeah, I know. Don't let me pull you
right off the table.
Right, so don't let me pull you down, good. Okay, so that's what I use for C6. For C7, I use wrist extension. So let me have you put your wrists up like this. So again, I'm supporting on one side of the joint and I'm pushing on the other. So don't let me bring it down. And I don't care if his eyes are open on this or not. Don't let me push it down. C8, you can either do flexion or wrist flexion or finger flexion. Go like this. A lot of people use finger flexion. This is not testing it. How do you grade this? Here, do this. Okay, try to pull your fingers apart. Can I grade that? No, because he's doing it. I'm not doing it. So go like this. Right? So from here, right, don't let me pull your fingers out. Good? Okay? And then T1, you can do abduction, adduction, both. Whichever. But check it from side to side. So let me hold your finger, let me hold you. Let you hold your fingers apart and I'm gonna try to squish them together. Don't let me. This, the person needs to have their eyes open for, or they cannot do it. Okay, and when they do it really well, they're really focused on keeping them. So here, let me do another, right? So you're checking them. Good. Right, that's T1. Easy? Okay, so DTRs. Okay, so for bicep, you have bicep, brachioradialis, tricep. Bicep is what level used for? It's used for five on the nerve root. I know musculocutaneous nerve is bigger than that, but we tend to use it for C5. Brachioradialis is 6, triceps is 7. Okay.
5, 6, 7.
5, 6, 7. Okay. So again, positioning. So I'm out to the side of his body. I'm supporting his arm. See that? I got it back here. Palpate the bicep tendon. If you're having a hard time finding it, say go ahead and bring your hand to your shoulder. Okay, relax. He flexed, I'm definitely on it, relax. You keep your finger on it, and you hit your finger. Can you guys see that okay? You're good? Okay, so it's this thing, you've got real little reflexes. You're a great patient, relax. I'm all right, I know where it is,
Okay.
thanks. Okay, you can see the contraction, you can see the muscle, the elbow move a little bit, right, flex, but you can even see it right up here really well, right? Okay, that's C5. C6, brachioradialis. How do you find brachioradialis?
No, you didn't.
There's no
Not exactly.
It's your drinking muscle.
Thumb up. What's the motion of brachioradialis?
Pure flexion.
Flexion, it's elbow flexion, right? So with thumb up, I'm gonna say, okay, what I want you to do is bring your hand up towards your shoulder. As soon as he does this, see this?
Yep.
Okay, here, can you see that, sorry. Can you see the muscle pop right here? Jeremy, do it again, look at Jeremy's arm. See it pop? So you follow it down, okay? Pop up and stop. Okay, relax. Okay, relax. Right, and you should be getting elbow flexion on it. Where'd it go? I feel like I'm not in the, I know, I'm just not. Do it again, up, relax. Drop it, thank you. Did you guys see that?
Yeah.
Can you see it on this side? Look, can you see it now?
Yes.
Oh, yes.
See that?
Yeah.
Okay.
Okay. It must be my awesome technique about the way that I'm standing. Okay, right, so you do it from side to side, you check it. Now, if you're getting too far medial, why can't I do it on you? If you're too far medial or too far lateral, you start getting these little hand movements, and people go, oh, I got it. It's not the hand, right? The motion of brachioradialis is elbow flexion, not hand movement. You're either getting flexor or extensor carpi radialis. Not the right muscle, not the reflex, right? So make sure they're in place. Triceps, I prefer to do it instead of seated. I know Dr. White likes to do it, I think that's the one he does seated, right? I don't like that. Is that it? Or no, he must do biceps. I don't know how you do triceps seated. Does he do that one seated? No, it's biceps he likes to do. Drop and relax. Relax a little more. Okay. So basically, remember that big chunk of connective tissue, the tendinous tissue that comes down? Think about it, you have that nice wide V. Come up a little bit from the olecranon and give it a good hit. You can see the movement, yes?
Yeah.
Okay. When you do this, drop your arm. Okay, it's so important that, you know how I keep bossing him around, and it's to get him to relax. I didn't hurt you. It's to get him to relax. Your patients have to be relaxed. If they're not relaxed, you're not going to be able to exhibit the reflex. It's not going to come out. With triceps, again, it's easier to get if you're either behind him or on the side. But if you do this, or do this, you're not gonna, it's really, drop your arm. It's really hard. He's really easy. Generally, if you go up too high, there you go, I went up a little higher. No, I can still get it. He's really easy to elicit a bicep or triceps reflex on. But most patients, as soon as you go into either too much abduction or extension, it'll wipe it out if they get too tight. You're being an excellent patient, and I appreciate that. Okay. All right, so say we do the deep tendon reflex, and when I do it on the left, it looks good, it looks healthy. When I do it on the right, it seems to be not the same, it's a little bit less. Okay, biceps reflex. Okay, you with me? Okay, so what type of lesion would we be looking at, and where would it be?
Biceps.
Yep, lower motor neuron at the level of
it's
C5. Okay, that makes sense, right? Okay. What about with muscle strength grading? What's normal muscle strength grading? 5 out of 5. And what's the scale?
0 to 5.
0 to 5. What's a 4? Slightly diminished. What if I have a 4 on both sides?
It's normal.
It's probably normal. It's probably, right, not something really pathological or a peripheral type of neuropathy. What if when I do it, it completely gives way?
Oh, good.
It's a trick question. What?
It would be 2.
If it completely, it's hard to get graded, but if it, like I go to push down, one side completely gives way, you actually have to ask a question. Why did it give way?
Because it could be normal for them.
If it created, man, it's never normal.
Oh.
Unless, do you have a shoulder problem? Or does that give you pain? Pain is a big one. A lot of times you'll go to grade, so you'll go, whoa, there's nothing there. And sometimes with some patients, they won't say anything like, oh, that hurts. A lot of patients will verbalize it, but if they don't verbalize it, you have to be thinking, is this a pathology that they have, or is it due to pain that they're letting it go? Well, if I can resist you more, but if I do it, that really hurts. Then the patient will just outright go, I'm not doing that, which is okay. That's okay. How do you chart that?
Not performed due to pain.
Exactly. Exactly what happened is what you performed. You know, I can grade the right side as being a 5 out of 5. The left side,
Wasn't good.
not, right, I can't grade this due to, not performed due to pain. That makes sense, doesn't it? And that's totally legitimate in your notes. Okay, what else do we need to do? That's everything for upper extremity, right? That's your very basic. Okay, so say I wanted to evaluate this patient, and this patient has local neck pain. It's just some local neck pain. And you're going to do a neuro exam on them, a general neuro exam. What are the components that you need to do? It's localized, no radiating pain, symptoms. What do you do? What's the neuro exam you do?
Monotone, like we do ortho.
Yes. That's
Let's do the
exactly
basic
right.
stuff.
It's still the same. So dermatomes, myotomes, deep tendon reflexes, but he's got no radiating pain.
Still.
Are you gonna do cervical, you guys had cervical ortho, right?
Mhm.
Are you gonna do cervical compression tests?
Yeah.
He doesn't
Okay.
have any radiating pain, why are you doing it?
To know
To see
that
if
it
it
was
elicits it.
performed and
To make sure there's not
proper
something
flow.
there, right?
Or something else.
What?
It's Broden's bead.
You're gonna start with neutral cervical compression, because you always start with the least invasive. Then you do A, which is lateral flexion, then you do B, which is maximum foraminal, which is lateral flexion, rotation, extension, something like that.
Both, all three.
Okay. Right, so you start with the basics and you go on from there, even if it's local pain. I'm dealing with this with one of the classes that I'm teaching. There's no radiculopathy, there's no radiating symptomatology, so I'm not gonna do dermatones. Thank you.
No, that's not.
My face looks way worse than that one that you're, yeah, I'm like, no, you do it all the time. I'm only doing these 3 tests because I'm pretty sure, I think the diagnosis is it's SI joint dysfunction. So I'm not gonna do a straight leg raise and 50 other tests that really take about all 3 minutes to do, right? You do all of it to make sure what if there's something
Rule it
else
out.
going on? What if it's local pain? And this was the discussion we had today. This was regarding lumbar discs. I'm trying to think of even how it started because my head was spinning just a little bit. It was on, in this patient, because we did so many of them, there's radiating pain, so I know it's a lumbar disc. Okay, providing that it can't, providing it's not something else, right? But I can't manipulate them because I don't have a flexion distraction table. So how do you treat this patient?
I thought you still could manipulate them.
Wait a minute, say what?
I said, I thought you still could manipulate them.
You can.
Why couldn't
How do you think the majority of chiropractors treat our patients and get them better every day with disc herniations and we don't have F&D tables?
That's what I was gonna say. What do you mean? Was that a trick question?
Not really, but it's questions that keep coming up. People are saying,
It's because it's being
"Oh,
brainwashed.
I don't have an F&D table, can't do it. Okay, so, and this is what I'd say to that. If he's got low back pain and radiating pain, and I believe it's a disc herniation, okay, let's go ahead and treat you. When I get to the manipulation, I say, lay down on your side. And if I put him in the position and go to set him up, and he's like, oh, it hurts, it's starting to run down my leg, that's a reason not to manipulate him that
Right.
way. You know, sometimes you cause a little bit of discomfort. It shouldn't be something like, oh, geez Louise, that's like terrible. You know, or that's really recreating
Yeah.
the symptoms. Then don't do that. Right? If it hurts that much, don't do that. I learned that from a mother, right? But if they're okay with the position, you go ahead and you treat them. So I was trying to figure out how they were coming to this, and I said, well, let's think about a disc herniation. Can you have a disc herniation and not, the whole thought about, do I have to do these tests that show that there's a disc with radiating symptoms? Does there have to be a complaint of radiating symptoms to have a disc issue? So when you think, when the person who doesn't say, I lifted this box and my back went pop and it shot down my leg, right? That's your typical scenario. Say it's just someone that has low back pain and then all of a sudden it's running down their leg. Could they have a disc herniation? Could they have had a disc herniation before it started running down their
Right.
leg?
It could
So
be
if you-
pre-existing.
If you think about it like that, like the person that goes, oh yeah, my back's been kind of bothering me, and then today I just bent over to pick up that tissue, and now I can't stand up and it's running down my leg. Did they just herniate? No, they just aggravated it enough to make it worse. Think about it like this, on the treating side of things, patient comes in and they've got pain, low back pain, it's running down their leg. You start treating them, it starts getting better. What does that mean? It starts getting better. Yeah, it may mean it's not as often, it doesn't go as distal, it's more central. Well, if a disc herniation can back up that way, can it also, present starting and then going out? It can. So just because there's not a radicular component or complaint, it doesn't mean that there's not the herniation there, right? It just may not be aggravated to that extent.
True.
I don't know. Just thoughts, because I know the information isn't, but for some reason, and I don't know if it's becoming so hyper-focused on doing tests and what the tests are for, that all of a sudden, some students are going, oh, I just won't do that. I'm like going, I know the knowledge was there at one time, I know you learned it, but now trying to put it into practice, you're like wiping some things out. So you have to think all the way through it. Any questions? I know, right now, because you're not actually treating one another for real, and you're not thinking it through, it's really easy, it's really logical. I just don't want you to get sucked up into the, almost, I don't wanna say the illogic, but they're like so hyper-focused on little things, like, it's not radicular, it's not a disc. Well, could someone have a facet imbrication and a disc herniation, or facet syndrome? Yeah. Right, can you have a canal stenosis and a herniation? Can the herniation be causing the stenosis? Okay, depending on how you're looking. They could also have a posterior lateral one and a central canal stenosis due to just the bone itself, say not even from a herniation. You can have more than one thing going on. You can have facet imbrication and SI joint dysfunction or SI joint syndrome or sacroiliitis or whatever you want to call it, which is going to give you a combination of symptoms. And that's why you do all the tests. Sound good? Okay.
I have a question. I
Sure.
had HMP years ago.
Herniated nucleus pulposus, which is a
And
disc.
and they asked,
Which is a disc herniation.
yeah, disc hernia, and
Yeah.
they asked me where it radiated, if it went to the side or to the front, and they
Mm-hmm.
said if it went to the side, it would be worse. But I'm pretty much thinking.
Okay,
about
so
how-
this is what I'm thinking. How to most, depending on what level was it at?
The L4, L5.
Okay, so it was lower. Most lower ones are going down the back of the leg. They usually go down the back of the leg, not the front of the leg. Front of the leg is usually a little bit higher. So if I'm thinking front of the leg, I generally think higher in the discs. If I think low back pain, it was low back pain and lateral leg pain?
Yeah.
Okay, depends on where it is.
It was more like forward.
Front.
Yeah, it was more in the front, and they said if I had it on the side, it was worse.
Well,
Lateral.
yeah, that's like, I missed that day in school.
That's fine.
No, I'm just saying, I missed that day in school. Going down the side, one of the things, and the front too, you need to rule out, is it the disc herniation that's causing whatever this is? You can have a disc herniation and something else going on. Or is this a cutaneous nerve that has either been, was there anything in particular that made it start? Like a
No, I
trauma?
was wrestling, and I just went.
Like a trauma? So trauma could have been to the back, or it could have been a compression issue somewhere here, which would have brought it out localized, meaning that,
It was, I feel like it was more tensile load.
okay,
I
so,
was compressing this.
okay. So here's the other thing. You have a disc herniation. Was that absolutely, you have to link it up, the herniation and the level, with the results of the exam. Do they fit? Do you remember that study? I think I probably talked to you about it from Johns Hopkins where they MRI'd all those men. 80% of the men had disc herniations. They had nobody had back problems. So what does that tell you about a herniation?
You can manipulate.
Well, of course you can manipulate it, but they could be asymptomatic. How many of you have a disc herniation? How many of you know for sure? How many of you don't know that you have a disc herniation? You don't. That's what I'm saying. If we MRI'd you, there's a really good chance you may have some.
Probably all of them.
It doesn't mean anything though until it becomes symptomatic,
That's true.
right?
Because I have it
So-
and I'm just,
So that's like the patient that comes in. The patient that comes in, and they've been to other doctors, they've had problems in the past, they're the first time in your office, and you go, what's wrong with them? And they go, I got a disc, right? You've heard me talk about this before. You have many discs. You got a lot of them. That was always my response.
it's funny
How
when
you
they
feeling
say it's
today? What's
slip
going
disc.
on? I got a disc. Love that. I got a disc. Okay, so in other words, they're telling me that their back pain, the radiating pain's coming from their disc. And I'm like, okay, great. I got my MRIs, I can show it, I can prove it. Okay, that's great. Let's do an exam. You don't need it. Here, I got the MRIs. I'm gonna do an exam because that's how it works in this office if you want me to treat you. Okay. We do the exam and I'm going, it doesn't really look like the disc. And then I stick my thumb in their piriformis and they fly off the table. Oh my God, my disc. No, it's not your disc, buddy boy, right? It's not. That's your piriformis muscle and I'm squashing your sciatic nerve and it's irritated right now. So let's treat that and watch how miraculously
You're gonna feel better.
the problem goes away, right? But people come in with, it's a disc. Now, the symptomatology on piriformis syndrome and lumbosacral somewhere, radiculopathy can be very much the same. But you have to make sure that you know, and you check. That's why I'm not just going to do the straight leg raise.
Right.
Straight leg raise can get fired off also. You can fire it with piriformis syndrome too, just because you're stretching it. So how do you know which one it is?
Gotta rule it out.
Got to rule it out. right? So if you go through all these things and you go, oh, this doesn't look so, but here when I do this, cough hard, Desjardins triad. Right? That was usually after I finished my neuro exam, I would start my ortho exam with. So I finished the neuro exam, this guy's sitting, and I go, so, Rob, if you cough hard, sneeze hard, bear down when you have bowel movement, do you get any pain or anything?
No.
No, great. Okay, so this is what I want you to do. Next is do a Valsalva's. And I used to tell them, take your finger, put it right here, keep your lips closed, like make believe you're blowing up a balloon. Blow real hard, don't let the air out. And they go, great. They increase the intrathecal pressure. Any pain? No, great. Okay. Let me have you extend your right leg out. Any pain when you do that?
Nope.
Do the left leg? Pain?
Nope.
Do them both at the same time? Any pain?
Nope.
That's Bectoruse, right? Here, right? This is the side that the pain's on. This is essentially kind of like a mini well leg raise. You do them at both at the same time. You're really tensioning those the sciatic nerves. Sorry, yank it on the cord if there's something there, it should bring it out. Okay. I never used to do slumps. If you do slumps, you drop the head. In addition, now you're really, really pulling it. From there, I'd have the patient stand up. You want to run through it? Is that okay?
Yeah.
Okay, so they would be in a gown or shirt off, right? So I could truly see. So what I want you to do is just bend over, touch the floor if you can, or go as far as down. Any pain when you do that? I'm doing an Adams bending, looking for scoliosis, right? I pick up my inclinometers and I go, okay, let's do it again, right? Now we're checking range of motion. I'm doing flexion, I'm doing extension, lateral flexion, left and right? Great. Now that I put the inclinometers down, I go, okay, now I'm doing Kemp's test because I do it standing. I brace one iliac crest. I go, okay, I want you to bend to the right. I rotate him and I push him back, right? And then I'm going to do the left side, holding this iliac crest, lateral flexion, rotation, extension. Any pain? Right? What's positive for Kemp's?
Reproduction.
Facet syndrome, that's not really it though. It can be a facet syndrome, it could be somatic dysfunction, it could be muscle spasm. However, that's not what the test is for. The test is if it makes it run down one side and then you have, right, you're looking at herniation, space occupying lesions, something like that. Right? So and then I try not to move my patient around too much from there. You can just sit. I do a straight leg raise on him, so he'd be laying on his back. I do one leg. Any pain? No. I do the other leg. Great. If he did, I do one leg. He'd say, yes, I had pain that was radiating. I drop it a little bit, dorsiflex, right? Do regards. Fine. Do the well leg raise, right? Do the opposite side. Check that. Same thing. I would do a hip test. I do Patrick Faber because I always throw in one hip joint, and that's the easy one. Flip him over onto his belly. I do Eli's, Knocklis, Hibbs, Yeomans. Eli's, Knocklis, Hibbs, piriformis stretch, Yeomans. I'm done. Right, that's my ortho test for low back. That was a whole bunch, but how long does it really take? It does. You know what takes the longest out of all that is measuring your range of motion. Especially if they're sticky, and they're always sticky. You know what I'm talking about? The wheels, when the wheels are sticky. So yeah, but you do everything so that you have a really good idea. Maybe he's got two things going on. Maybe there is a facet syndrome and a disc herniation and somatic dysfunction and myospasm. Sorry, it can be all that stuff, right? So you just do all of it. Okay, lower extremity. Okay, dermatomes. Right, so I would I'm going to ask him, bring your shorts up to about here, because I want to get the majority of it. If you remember, come straight down the front of the thigh. The patient complained he has numbness on his thigh. Okay, so I'm going to say, same thing, I'm going to run this down, I'm going to have you close your eyes, have him feel it. Okay, go ahead and close your eyes. Tell me, does this feel the same as this? No, it doesn't. Oh, yes, it does, sorry. Yes, it does. Yes, it feels the same. But remember, he came in with a numb feeling on his thigh. So what do I do? So you said you had numbness on your thigh. I'm going to ask him, where's the numbness? Where is that numbness? He's going to go, oh, it's over here. I'm going to go, oh, okay, let me check over there. So I'm not going like this now, coming on that goofy angled pattern thing. If it's over here, I'm going to go, well, is it here, is it here, is it here? Checking out this area. You can use a grease pencil, mark it out. If it's just on the lateral thigh, you're talking about lateral femoral cutaneous nerve, which is not going to show when you do your dermatome scan. But you have to go back and you have to think, right? Well, what was the chief complaint? The chief complaint was
Numbness
numbness
on
on
the
his thigh. Where? Can you say where? On my right thigh. Okay. If you didn't get that from him, point to it during the intake, but then you do the dermatones and you go, they're normal. I'm saying, so where is that numbness that you were saying you have? Oh, it's right here. Oh, okay. Well, that would explain why. That's a normal dermatome testing, right? Comparatively. However, the patient has lateral thigh numbness, which is correlated to, an issue with the lateral femoral cutaneous nerve, and that's what you'd write in your note, just like that. You have the knowledge. You just have to put it together. Take off your shoes. Right. So on the thigh, that's 2 and 3. Forget about the knee. Do you remember that? Don't forget about circling the knee or coming on angles or twisting and twirling, and because there is no definitive on that. Okay?
Give me your socks also.
Yes, please. Yes, absolutely. Socks off. And your patients, this is perfectly normal of what a patient will do. I'll ask them to take their shoes off, and I should have said, and normally I would have, shoes and socks off. Socks too? Yeah, take them off. Oh, but it's so hard. I'll help you put them back on. But I can't test you so well with your socks on, so take them off. Okay, so L4 is going to be medial leg, right? So, same, right, we're continuing. So does this, and just come straight down, medial leg to medial malleolus. Does this feel the same as that?
Yes.
Can you see?
No.
So get up and move, will you? Because I don't know how to elevate them any higher. Okay, is that better? Can you see now? Stop that.
I'm just trying to help because somebody's not here.
Are you gonna airdrop
Oh,
that,
sorry.
Fuzzy?
Okay.
Yeah, it's on my YouTube. Go ahead and hit the like button, subscribe.
Subscribe and like.
Okay, L5 is lateral leg, right? Come down the lateral leg. It does come over the top of the foot. Just make sure you nail between the first and the second digit.
Mm-hmm.
Can you see that?
Yep.
So, and I feel like normally would not be doing this, but I don't know where to go. Okay, here, I'll look around the other way. Let's see what that's at. Okay, I'm not happy about this at all. Okay, so, right, it's a comparison. This right into this area here. Okay, so compare them from side to side. For S1, where are you going?
Foot.
Just the side of the foot. Can you see? Sorry.
You're good.
Can you see? Here, out the pinky toe. Lateral foot, pinky toe. On this side, see? Can you see? Lateral foot, out to the pinky toe. That's it. Stay off Stay off of the bottom of the foot, because different charts have slightly different variations. Even the back of the calf is kind of variable. That posterior thigh, pretty much midline, you'll hit S2 if you need to go down that far. But as far as S1, it's always going to be lateral edge of the foot into the pinky toe. That's consistent, okay?
So for L5, you don't have to do top of the foot, but do you recommend it?
So this is what I recommend. When you're in clinic, do top of the foot, because Dr. Cruz insists. In practice, I did not regularly do it unless there was some sort of radiating issue. That right there where it pops out, that's where the deep peroneal nerve pops out and goes cutaneous. So being that I'm kind of testing it motor anyway, if I'm looking at the roots, not the peripheral nerve, I'm comfortable not doing it. But for your sake in clinic, I would develop the habit of doing it that way, okay? Because he prefers it that way. You have to think through it depending on how your patient presents, what the problems are, what other tests and components you're using. Myotones for the lower extremity. What are you doing?
Hip flexion.
Which is what level?
L2.
L2, L1, 2, 3, L2, 3, yep. 1, 2, 3 is pretty much how I look at it. So there's two ways of doing it, and there's one that's better than the other. So I'm gonna show you what not to do first, okay? So go ahead and scoot back just a little bit, will you? So I'm gonna brace in here above the knee joint. Go ahead and try to lift your leg. Yeah, how am I gonna measure that? Go ahead. I can't really tell. Raise your leg up. Don't let me push it down. Do this one. This one you can measure. When he's pushing up into you, it's really hard to tell. I think it's about the same. But this I can judge by movement, okay? So that's L1, 2, and 3. If you're testing up that high, where do most disc herniations and lesions in the lumbar spine occur? L4, L5, and then L5, S1. What about the neck? C5, 6, C6, 7, yeah, right? So we're talking about the lower portions, lower areas. So L4, 5, and 1. What are you guys doing for L4?
Dorsiflexion inversion.
Inversion.
With dorsiflexion, you blacked out. Okay, Jeremy over here is doing quads for knee extension. That is L4. I do not recommend it. As a matter of fact, I say don't do that. The reason why is it's a big muscle. It's harder to grade.
Up and in, dorsiflexion.
Yeah, up and in for dorsiflexion, for tibialis anterior. When you do, and a lot of people like to choose the big muscles because I'm strong, I'm big, I can do that. Yes, you have to work harder for it, but more importantly, it's difficult to grade. It's difficult to pick up these subtle nuances because they're such big, strong muscles. I'm telling you, the better choice is to go to the feet and do 4, 5, and 1 there. So, can you see okay? You guys back there are good? Angela, Jeremy, yes? Okay, so bring the foot up, bring it all the way up. You put them in the position, hold it right there, okay? And again, I'm on either side of the joint, so I'm supporting behind on the distal lower leg, and I'm gonna push down with kind of an outward circuit motion. So don't let me push it down, good. This one, I'm gonna bring it up and in. Oh God, normally I would be moving, but it's down and out, okay, is the direction of the push. That's good, I would grade it 5 out of 5. Big toe is super simple. Bring your big toe up. Hold that there. No, up. No, hold it up.
Should I cheat?
Don't let me push it down. You have to really think about this.
I cheat my toes.
Hold it up. Don't let me push it down. Good. Nice and strong. That's
Do
L5.
you do this with their feet hanging off the table, or are you okay with the foot
You can
flat
do
on
it.
the table?
I prefer it down. I think it's easier for the patient to do. This table is a little bit high. You can do it up, but they really have to think about it because you have to, right? It's more difficult.
Well, it's hard to just do big toe. That's
Right,
right.
and you can do all of them, but that's the only one that we're really checking. So, and then S1 is basically plantar flexion and eversion, right? So hold it like that and don't let me, and now you move your hands, right? You're supporting here and you're pulling up and in, right? This one down and out,
You can see, don't worry.
and
We good.
this way, okay, this way, hold it there, right? And you're pushing up and in, okay?
Okay.
As long as you're down here, you could do a couple things, depending on, pardon?
The reflexes.
You can do the reflexes, right? So you can do, and normally I'm kind of squatting, and you shouldn't be doing it like this, sorry, but you're palpating. Here's tibial tuberosity, here's the inferior patella.
So-
You know that, right? You need to be between those, so until you get it, actually mark it off, come in with the point on your tomahawk and hit it, right? Sorry, I cracked you a little, right? So you grade it side to side. When you're down here and you do the Achilles reflex, like somebody today when they were doing an Achilles reflex, they really had the person in dorsiflexion and they couldn't quite, oh, you've got such good reflexes. It's really hard when you pull someone up into strong dorsiflexion. If you pull them up just a little bit and really lightly, rest your hand underneath and then you whack them, you can see it go down super easy, right? So, okay. Let's do hamstring reflex. I just don't want to catch myself in my, thanks. I don't want to catch myself in my dress and fall flat on my
Try.
face. Thank you. Face down on this very comfortable table. Okay, hamstring reflex. Okay, 2 things. Are you okay?
I'll survive.
So 2 things you can do here.
Flanking, yeah.
One thing is, are you relaxed?
Am I relaxed? I mean,
It's
that's,
really
My
looking.
table is very uncomfortable.
You
That's
can
right.
do a superficial plantar reflex just for the heck of it, right? Which I used to do when I had my patients prone. He's not so comfortable, I'm not gonna dig in.
It's like,
But anyway, hamstring reflex, right? So drop your leg. So on the hamstring reflex, you don't want his leg all the way up like this. You want it somewhere between full extension and flexion. So, Rob, bring your heel to your butt. Okay, see his tendon pop out, drop, relax. Right, I'm definitely on the tendon, relax. Keep your finger on the tendon, and then you hit it. He's got really good reflexes, you can really see it. Now, if he wasn't wearing pants, can you guys see this here? Come
Yeah,
look.
I can see it.
Oh, I thought you meant if he wasn't wearing pants.
Oh no, if he wasn't, you might see a little bit of movement if he had his scrubs on, maybe. But drop, relax. Relax.
There's nothing.
It still goes, even when he's relaxed, it still goes, right? So notice how I'm on the side, right? I'm facing the head, kind of in a fencer's stance. Instead, I'm not doing this. I'm not in between his legs, I'm to the outside, right? So the leg, the hand that's palpating, that you're hitting, is also supporting the leg. And then you hit that thumb. Okay? Sorry.
You got tight hammies, cause
I don't, that's what I was wondering, or is he doing, or is it because of pain? I'm not really sure, because he's like directly on his kneecaps. That's why I was asking.
It's a little bit
Drop
of
it, see his tendons right there, drop and relax.
Yep.
You guys can see it, right? And this is probably one of the, go ahead and come on up, because I know you're uncomfortable, sorry. That's probably one of the more difficult positions to grab. I know you're supposed to be able to do this seated. I think that's ridiculous. I don't know how people do it seated. I don't think you can get a really good smack on it. I think it would be hard to grade.
projects that putting your hand on the hamstring to feel that hamstring twitch when you do it.
Come look. No.
No?
No, you don't have a hand. I mean, you don't have one to watch. I'm sorry.
You're good. It's really not that
Right,
bad.
so there's the tendon. So if I'm hitting it like this, where is my hand gonna be?
I
Which
understand.
hand?
It's like you
I don't
gotta
have
go
any
another
more
one.
hands, right? So see this? Watch. You can see it run all the way up, right? If you
Yep.
get it, he's sorry, go ahead and say. He's got a really good one. A lot of patients don't have really great reflexes. You can see, unless anybody else wants to try, because he's a great experiment. Anybody want to try him?
Sure.
Actually, come try him. Let's not